So welcome, good evening, and welcome to Am Abel Foundation's Medicine Makers, where if your destination is a career in medicine, we can show you how to get there. I'm very excited for this evening's show, but a few housekeeping points before we start. You can stream us live on cantv.org/hotline. You can watch us on CanTV Access channels 22 or 21 or 99. You can stream us live on Facebook. I would recommend for you, if you want to call in to this show, this amazing show this evening, you can call us at 312-738-1060. We have people standing by the phone to answer questions. So my name is Dr. Toyin Adeyemi. I am one of the mentors and board members of Am Abel Foundation, and I am super excited to have our guest today, Dr. Takijah Heard. And this woman's amazing physician. Born here on the south side of Chicago, completed her medical school at the University of Chicago here in Chicago, and then went up to the East Coast at the Boston Children's Hospital, where you completed your residency and a fellowship in public health and in pediatric neurology, and really set the standard for what needs to happen for epilepsy research, both in the public health and in the pediatric world. You've traveled around the country speaking. You've traveled internationally to Kenya with the Am Abel Foundation. Yes. In addition to that, Dr. Heard does a lot of work. Her teaching skills, she's gotten tons of teaching awards, has been featured for your work and your passion for pediatric epilepsy on WGN, on NPR, on Fox News Chicago. So we're really privileged to have you here. You've traveled with some of the mentees to Kenya to do some work on epilepsy research. So if you guys aren't impressed yet, there's more. She was featured in a book, a recent book on Against All Odds, profiling Black women in medicine, yes, and the rise in that. So that's amazing. So you're currently in the North Shore Health System, head of pediatric neurology, established a program for pediatric neurology surgery. We're excited to have you here. So if you have questions, please call in to Dr. Heard. So could you tell us a little bit about your journey into medicine?
So I will say that my journey to medicine sort of began with, sort of watching various people like the Cosby Show and Bill Huxtable. He was the first sort of Black person that I saw that was a physician. My mom, as I was growing up, she was ill, and I recognized how physicians sort of influenced our life, and I wanted to be that person for many other people's lives. Going to University of Chicago, we had to do a research project between our first and second year, and I wanted to do something that I hadn't really experienced, and that was seizures. And so between first and second year of medical school, that's where my research began, and I ended up falling in love with it. I've always loved kids, and so this sort of was a way to bridge all of those things together.
And we do have quite a few kids in the program who are really leaning towards pediatrics, and this is just to have mentors like you in the program is really, really exciting. So thank you for sharing that journey. So let's dive in, because we don't have a lot of time. What is epilepsy, and what else do people call it? Some people call it seizure, some say epilepsy. Is that the same thing? What is that?
They're different. So seizures is something that happens. Epilepsy is a disease state. So seizures is something that can happen, and if you have two seizures, that's whenever you get the diagnosis of epilepsy. Seizures can happen for various reasons. It could be because your sugar's too high or your sugar's too low, because electrolytes are different, because you may have a brain bleed. But epilepsy itself is whenever you've had these two seizures for unknown causes, meaning untriggered, then you get that diagnosis of epilepsy.
Wow, that's a really clear distinction that a lot of people use those terms interchangeably. And we do know that a lot of children have seizures when they're ill. Remember, little kids, some kids, their moms or dads say, oh, every time they get a fever, they're going to have a convulsion. It's something people used to say in the days. So what are these seizures with fever? What are they, and who gets them?
Yeah, so febrile seizures, they usually happen between 6 months and 6 years of life. They have a peak usually around 2 or 3 years of life. And usually it's the fever itself that's sort of causing the actual seizure itself. It's the rate of rise of the temperature, not necessarily the temperature. So it's not as though every time you get to 104 temperature, you're going to happen. It could be you've gone quickly from 99 to 102, and then you may end up having that convulsion or that febrile seizure.
And is that something that people outgrow? Does it run in families? And is that why sometimes people are like, let's get the temperature down so quickly?
That's right. Right. Yeah, and so it can run in families. Oftentimes, grandma knows. So so they'll say that the father might have had these whenever he was little. Mother might have forgotten, and so whenever the father now has a child, now it's sort of something that may sort of come up again. And so taking off clothes and truly making them ambiently less warm is helpful. So taking off clothes, getting them something cool to drink if they're able to, and then putting sort of damp cloths on them to sort of keep them cooler is helpful.
So that's a perfect lead into the question I have around what to do if you're around someone and they're having a seizure or they have a diagnosis of epilepsy, because what you described is something that a caregiver might know, a parent or somebody who knows. But what happens if you happen to be in a public place and you see someone who seems to be having a seizure? What are things that you can do as a non-medical person?
Yeah, so biggest thing is, it's coming from the brain. There's nothing that you can do to sort of stop it. So it used to be an old wives' tale to put something in their mouth, so a wallet or a spoon.
Right.
Yes, and so definitely do not do that. Oftentimes you end up chipping a tooth, and that tooth will go down into their lungs and cause additional problems. So do that. So don't put anything in their mouth. Lie them on their side. Lying them on their side will open their airway. They cannot swallow their tongue. Their tongue is attached, and lying them on their side will just keep their airway open. Sometimes they will drool, and sometimes they may bite their tongue. If that happens to be the case, then you may see blood. It's blood because they've bitten their tongue or their cheek, not because they're vomiting blood. And it's coming from their brain, and so there's nothing you can do like holding them tight to get them to stop. It'll stop on their own, usually in about 2 or 3 minutes.
So Dr. Heard just went through 5 myths that are out there and just really told us what this is about. It's coming from the brain, and just really all the things not to do, some of those things that we've heard about a lot, about things people should do. So that's really important to know, that you don't want to run away, because there's sometimes, and if we do have time at the end, I want to talk about a little bit about some of the stigma that may have around epilepsy, especially in our communities. If we do have time, we'll get to that. So we kind of touched a little bit about does it run in families? So is it always hereditary, or are there other times that it happens for other reasons?
Most of the times it's just happens for other reasons. If it happens to run in the family, it's not usually like an autosomal dominant, autosomal recessive, or X-linked type of hereditary state. It's more maybe a cousin may have it and another cousin may have it, but it's a different type of epilepsy that they usually have.
Okay. And there are medications for epilepsy, and I know you do a lot of research around surgical things, and we'll talk a little bit, and you actually have some things you can show us. So one of the things we've talked a little bit and zoned in a little on the children and the febrile seizures, because you said most times are 6 months. What happens? What are some of the other things that can cause epilepsy or seizures? Epilepsy.
Yeah, so generally I feel like epilepsy is sort of developmental. So sometimes, babies are born, so there's neonatal seizures. There's seizures that can happen as they're sort of entering school, and those are the absent seizures or the pediatric seizures. And then sort of as they get older in teenage years, they can have the juvenile myoclonic epilepsy. And so those are some of the different types of epilepsy that one can have. And then as a collective group, there's something called idiopathic generalized epilepsy. And so those are the epilepsies that generally people will outgrow, and that includes the absence epilepsies of the world. Usually whenever they get to double digits or a teenager, they will outgrow them. Or if they've been seizure-free for 2 years, then usually that's the time in which they'll outgrow them as well.
Wow, that's great. And then what about adults? Do adults just, I know you're in pediatrics, but do adults just sometimes present with seizures that they never had during their childhood?
Right, so that's why I sort of feel like it's developmental. Just like, women have periods and they sort of appear at some point in time in life. It's very similar to other people whenever they have their epilepsy. Somebody may have never had a seizure until they're 34, and then they develop epilepsy in that way, and adults just as well.
Okay. So I want to talk a little bit about surgery and some of the work you've done and some of the things. So we've kind of always thought about epilepsy and medical therapy. So are there surgeries, and what are some of the exciting things and I know you have some equipment you can show us, just surgeries in general for epilepsy?
So surgeries are oftentimes helpful if there's an actually pointed focus where the seizures are coming from, and that's where we do some of the open brain surgeries that may sort of resect the area that the seizures are coming from. That area happens to be defective and only producing seizures generally. Our job as the epileptologist is to make sure that brain tissue is not eloquent. It's not cortex that we need for vision or for memory, for speaking. And so once we identified that it's only there to seize, which is something that we don't want, then we can remove that area. Neurosurgeons do that. There's a special robot now called Rosa that can be helpful for that. And so they'll do that and they can remove it that way. Sometimes they'll have like a laser ablation where they'll sort of remove certain types of tumors that way to remove the seizure and the symptomatology that comes along with it. And then if you happen to have like a generalized epilepsy, sometimes you can do something that's a little bit less invasive, and that's like the VNS, and that's this this device that we have here.
Show you that device.
And so the VNS has these two different modules. This is the older model, and I just put a dime here so you can sort of get a general idea of the size of it. And so this model, the Aspire SR, and then we also have the Sentiva. The beauty of this is that they're getting smaller, on top of the fact that this one has the ability to have AM and PM settings. And so you can have different settings, and this is the wand that's helpful for identifying the treatment type that comes along with the device. And so this is the other piece of the device that we sort of use in the office to sort of change some of the settings whenever it's necessary.
Wow.
And then the last one is called an RNS, and the RNS is actually something that you place in the skull, and it sort of modulates the different types of interictal activity as it sort of goes into the seizure-like activity.
Wow, that's impressive, because I mean, these things have, like you said, they are getting smaller. The technology is advancing. There's robotic surgery. That's very exciting. So I'm gonna kind of go back to something that's medical therapy, marijuana. So I do adult HIV and adult primary care, and I do know that there's a whole list of conditions where we do know that medical marijuana has some efficacy. So what is the role, if any, we've talked about prescribed medications, of which marijuana is one of them. It can be medical marijuana. We've talked about surgery. So medical marijuana for epilepsy?
So actually it's sort of exciting. This year they opened up, the FDA sort of has now given us a new medication. It's called Epidiolex. So it's interesting because it has epilepsy within the name, and Epidiolex is the first FDA approved medical marijuana. The beauty of this is that you always know the exact amount of active the cannabidiol that's in it, and it doesn't have the THC, which is the hallucinogenic portion of it. And the patients that I have on it have been, remarkably made better with the addition of this medication. Thus far, you have to be pretty refractory, meaning pretty intractable and difficult to treat epilepsy before you're allowed to use it. But the ones that are on it have noticed that they've had less seizures with the starting of it.
And that is very exciting. First of all, that in terms of having FDA approval for that, but also knowing, like Dr. Heard just said, that this is for refractory. This is not like, I have a friend on it, I want that. It's not first line. You've seen an epileptologist. You've actually had care. You've had stepwise therapy, and then this is as an add-on. So is it still? It's not in clinical trial. It's approved if it's approved for by the FDA. So that's exciting.
Yes.
So we've talked about all these things. So a little bit about sudden death.
Yes.
With epilepsy. So this sudden unexpected death in epilepsy, and recently in the media and stuff, we've had celebrities, we've had people with seizure disorders and sudden death. So can you tell us a little bit about?
Yeah. So the name of it is the acronym, and then we call it SUDEP, Sudden Unexplained Death in Epilepsy Patients. And so the name itself sort of tells you a lot, that it's sort of sudden and it's unexplained. In retrospect, we've done a lot of research to identify the cause. And so sometimes it's sort of the position in which they are in, and it usually happens whenever they're sleeping. And so we're trying to do various different types of, other types of technology, like the watches. So some of the watches have like this ergonomics that sort of allow you to know whenever the patient is prone. And so whenever they're lying in that position, it can sort of alarm, one to say, maybe this person should be turned in a different position. That's sort of the future of where we were going. The name of the watch is called Embrace. The beauty of SUDEP is that we have a program that's here called the Danny Did Foundation that's actually up in Evanston, sort of named after a little boy named Danny that happened to have passed away because of SUDEP. And they've been been pioneers in helping trying to increase the education about SUDEP and also increase some of the devices that may sort of prevent SUDEP from happening to many people.
Wow, that's great. I mean, that's just amazing, the amount of technology and the amount of research that's going into epilepsy, and having people like you as pioneers and people who are really engaged in that process is really, really exciting. Kind of when you were talking about the monitoring and the position, I was thinking almost like SIDS and really trying to figure the sudden deaths, and the more we know about the conditions. And that's why when we have this large group of unexplained, it's always good for researchers and people who have both from a clinical and a public health view to kind of go back and say, hey, let's see, what's the commonality, what's happening. So that's really exciting. So now back to, say, a parent or a child living, who with epilepsy. How is life different? Are they, going to school and things like that? What are things that are different, and what are the things that that we need to know in terms of just living the highest quality life with epilepsy?
So my goal is to try to make sure that these kids are just as normal as all the others, right?
Yes.
So there's only a couple of situations in which the seizure happening in that situation is a problem. So obviously it's in water. And so I always encourage my kids to now take showers all the time. If you do happen to sort of love your baths, then somebody has to be in the bathroom with you, just in case it were to happen. I didn't want you to slide up under the water. The drowning is more of a problem than the seizure itself. Another one is just for the little ones that sort of like the playground, is sort of the climbing. And so during the time in which they're on the playground and they happen to climb higher than their height, then sometimes their fall is more of a problem than the seizure itself. Outside of that, playing sports, I've sort of tried to do all that I can to encourage everybody to play sports. I don't know if you remember one of the Olympians that was truly one of my role models, which is FloJo. She was obviously an Olympian and fair in track.
Correct.
Yeah, we have two twins, the Barbers, Tiki Barber and his brother. They both had epilepsy and they're NFL players. But there's been hockey players, so sports and all of those things. The one thing that can be a little bit bothersome is driving.
Yes,
so after you've had so after you've had any loss of consciousness, whether it's from seizures or from cardiac arrhythmia, you're not allowed to drive for 6 months. In the state of Illinois, they may sort of push you down to 3 months, but usually I'll say no driving for 6 months, because obviously the seizure behind the wheel of a ton vehicle is more deadly than the seizure itself for you and others.
And there's nothing, physicians are great at advocating for our patients, but let's face it, people love celebrities. So having those like superstar athletes, like, talk about epilepsy and say, look at me, I'm living a normal life, I'm excelling, is really important. Because there's stuff around the stigma around epilepsy, or kids not wanting to go on sleepovers, or their parents not wanting them to go on sleepovers, which kind of shrouds the whole, and makes the kids feel different from other people. So in terms of when they're controlled, it looks like we have a caller coming in. All right.
Hi there. I have a question. I'm a school teacher, and I have a particularly difficult student with behavior problems. And what I believe I'm witnessing are probably fake seizures because of his behavior. And I just want to know, as a layperson, what are some of the clues that we may have? Obviously, we have to seek medical attention to that setting, but what are some of the tools that we may have just as regular lay people to recognize whether or not this is a behavior issue versus an actual seizure?
Great question. So there's.
You want to repeat that just a little bit, because I don't know if it projected well on this for the viewers.
Yes. So this is a teacher calling in about a student that may have what she was considering fake seizures. There's a couple of names for it. It could be either pseudo seizures or non-epileptic seizures, and she was asking if there are certain types of features that lets her know that these happen to be seizures, like epileptic seizures versus non-epileptic seizures. So usually seizures are very characteristic and stereotyped, and so if you notice that each time he or she does it, it's the exact same thing, then they're more likely to be seizures. If they happen to not be triggered, they are more likely to be epileptic seizures. If it happens to occur,
about a student that may have what she was considering fake seizures. There's a couple of names for it. It could be either pseudo seizures or non-epileptic seizures.
And so with that being said, oftentimes people that are having non-epileptic seizures won't harm themselves. So if they're sort of in a certain position, they'll sort of be able to still maintain their composure, is another example. But the biggest one is that all of their seizures should stereotypically be exactly the same and should not be triggered by them getting in trouble or anything like that.
So thank you, caller, for that question, and it's really good that we're having people outside of, the healthcare field or parent, other places where children are. School teachers are an important part of care, and also just for the children. So we talked a little bit about, with the children. We talked about medical therapy, and before we end with talking a little bit about awareness and things we can do for promoting awareness around epilepsy and the research that's going around that. Can people ever come off medications, or is it something that, so you did say that the febrile seizures, a lot of times the kids outgrow it, but if someone's, say, on medications already, when is it okay to come off medications?
Yeah, so after they've been 2 years seizure-free, then usually we'll do an EEG, see that that happens to be normal, and then wean them off of their medication. And usually that time prior is the time in which they have seizures, and usually the time after they're weaned off of medication until adult life, they don't have seizures. So that's what makes my job very rewarding.
Yes,
Yeah.
That's great. And then also when they're trying to apply, high school kids taking driver's ed, they're trying to apply for a license. As long as they're seizure-free and well controlled on their medications, there is not a reason why they couldn't do anything else like everyone else.
Absolutely.
That's perfect, and that's really important. So in your career, so you've been doing this, because we have a few more minutes, and I really want that aspect of that. You've had, your career in Chicago, in Boston, you've been in Texas, back in Chicago, clearly a teacher, an advocate, a mentor. What are the things that you've talked a lot about, the myths and the things we shouldn't be doing? What are the things for people who are listening out there around epilepsy and the research and things that are going on that you'd like them to know? And for any of our mentees or kids in high school and college who are thinking about pediatrics and neurology, and we're all kind of like, the brain is such a mystery. What are the things or that you would just like to impart on them as we close out?
Yeah, that, the brain is everywhere, and all aspects of your body sort of needs that sort of neurologic input. And so that's one thing, that if you enjoy medicine, that the medicine that comes from neurology sort of imparts every portion of the body. And so, for those that have HIV,
Yes.
there's a different type of change that happens in the brain that sort of can put us together.
Correct. And I work with a lot of the adult neurologists, and it's like, it's very exciting.
Yeah, right. So you can collaborate with a lot of different people within medicine. That's including physical therapists, occupational therapists, speech therapists, teachers like just called. And so, there's a large amount of education that comes as a neurologist for all aspects of your job.
And that's exciting. And then in terms of the awareness and stigma around what has helped, what have you found that has helped? And do you see that sometimes parents come to you really just like crushed the first time it happens? They've heard about the stigma around it, they're worried, and have you seen some of those people then turn around and become advocates and ambassadors for
Epilepsy, absolutely. And so that's one reason I wore purple, because
Yes.
purple is the color of epilepsy. But in general, epilepsy is not contagious. So your child playing with another child with epilepsy is not a problem. Epilepsy is very common. 1 in 26 people will have epilepsy in their lifetime. 1 in 100 will have, if you take a cohort of 100, one of those people does have epilepsy. The difference is that epilepsy is not as obvious as cancer, because, you still have your hair. You look very similar to everybody else. And I want everybody to start to treat people that have epilepsy just as similar as they treat people that have asthma.
And that's really important. And that's one of the messages that with the whole thing is that when you have physicians, and that's what Am Abel Foundation, which you're a very active member in, is important, is when we try to get, the next set of healthcare heroes, right? People who are giving back to the community and who do work not just in the silos of the clinical setting or in the hospital and research, but who are out there advocating for the research, making sure they're getting the best for their patients, and talking to the community about that. So this is really, the expertise that we had for free on this show is amazing. And I don't know if we have time for any other caller. It looks like we're at a wrap, but thank you so much, Dr. Heard, for sharing all your work, all your expertise on epilepsy. You gave us a rundown of the types of causes. You talked about childhood seizures. You talked about medical therapy. You talked about the exciting surgical options that are there. We talked a little bit about marijuana and the newly approved indications, and what to do if you happen to be around somebody who's having a seizure. It's not to run away. It's not to pick out your cell phone, except you're calling for 911, is to actually do what you've told us to do. So that's really very helpful. Thank you so much for being on the show. And again, for our people watching out there, our website is iamabel.org, IAMABEL.org. And again, this show, Medicine Makers, is one of the many things that we do in terms of trying to get people into a career in medicine. And you could be paired up with a mentor like Dr. Heard. So thank you so much for your time.